Hello, everyone. It's a real honor to be here. Thank you for the invitation. I was asked to come to talk about what I've been doing with my life for the last 10 years. I'm 41 years old, trained as a pediatrician and a preventive medicine doctor, master's in public health. And all around me, over the last 10, 15 years, I saw technology evolving. You know, we can call up an Uber and get it here in 3 minutes, but is that really affecting the daily lives of us being a doctor and our patients being patients? Sometimes it looks like all that technology sort of leapfrogged and skipped us over. So I don't think that's right. I think it's best to sort of leverage the technology and see what that looks like. So I'm going to talk to you today about what I think the future of healthcare delivery looks like. And I'm sure it's going to make a lot of you uncomfortable. And that's okay. I encourage you to be uncomfortable. I encourage you to challenge me. Don't throw too many tomatoes, please. But just think about what technology can do for us today. So that being said, on June 29th, 2007, the iPhone was released. On June 30th, 2007, that was my last day of residency. So I don't think that that was it was a fluke. The iPhone has enabled me to do what I do today. So I just really got lucky. I was sort of born in the right place at the right time. And I also was just this curious, student who always asked why. And so I said, the iPhone exists. Can we use it today to deliver care? Oops, sorry.
When you grow up, you tend to get told that the world is the way it is, and your life is just to live your life inside the world, try not to bash into the walls too much, try to have a nice family life, have fun, save a little money. That's a very limited life. Life can be much broader once you discover one simple fact, and that is everything around you that you call life was made up by people that were no smarter than you. And you can change it. You can influence it. You can build your own things that other people can use. Once you learn that, you'll never be the same again.
I didn't see that back whenever I was starting my practice. But I had this naive confidence that, hey, I could do something. I could change how doctors and patients communicate and get care. So in September of 2007, I launched my first website. And that website was jayparkinsonmd.com. I announced to the world that I was a different kind of doctor. How this would work is pretty interesting. You would go to my site, you would click on Make an Appointment, that would bring up my Google Calendar. It allowed you to tell me your symptoms and your address, and I'd make a house call. I live in Brooklyn, in New York City, so I kept it within 2 neighborhoods, Williamsburg and Greenpoint. And so I visited people in their homes. It's a very young, hip sort of neighborhood, so they were my people. I was young. And I was their doctor. I was the neighborhood doctor for that area. So I'd see you in your apartment, and we'd follow up via email, maybe via Skype, maybe another house call visit. But you'd pay me via PayPal. I charged about $150 a visit, and I could do about 7, 8 visits a day, really hustling, right? But my overhead was nothing. It cost about $1,500 to get this thing started. And, I could just be an old-fashioned neighborhood doctor. And this is sort of what this looked like.
In Brooklyn, who's mixing vintage healthcare with new age techniques. He has no office, so there is no wait time, of course. And if you need him, all you have to do is send him a text. Fox 5's Rob Malcolm checks out the practice live tonight in Williamsburg. Rob.
All right, Ernie, well, you live here in Williamsburg. This doctor is waiting for your email. He says people better jump on board. The future of medicine is moving online. With bag in hand, Dr. Jay walks the streets of Williamsburg looking for patients. Where's your office?
Right here. Here's my equipment right here. I don't have an office. I am strictly a house call physician.
He launched online September 24th already. He's had 50,000 hits. Now, if you need him online, he's just one click away. You'll find a real-time schedule, instant message, or email your request, and he'll try to show up in an hour.
The first thing, all right, that's embarrassing. So anyway, you get the point. By the end of the month, I got 7 million hits on my website, which is, what is that, like a third of Australia, right? So I would say that it's probably the first viral doctor practice. I would also say that it was the first mobile-dependent practice ever done. But, all that traffic, it was mostly just the local blogs, the local news, the tech press. Everybody was sort of getting excited about, this young house call doctor in Williamsburg. It was just prepackaged for news. It was a perfect story. So I took advantage of that, and, my practice was booming. But, the issue here was it's not that scalable, right? It was raining, it was snowing, I was just, slogging. It was tough. So one of those 7 million folks that reached out to me and visited the site was a gentleman who had recently sold a company to another tech company, and he was looking for something new to do. So he said, I think we got something here. I think there's something we can do with this new way of delivering healthcare. And I agreed. So we started a company called Hello Health. We were able to go out, and with this sort of press and the idea and sort of my ability to sell something, we were able to raise about $10 million to get this started. So the best way to describe Hello Health is it's a tech platform. This is about 9 years old now. They're still going. It's a tech platform. So it was sort of like an EMR meets Facebook at the time. It was meant to power an office-based practice, and it was also meant to power communications in between the office visits. So in order to prove this out, we built a few practices, one in Williamsburg, Brooklyn, just 2 blocks away from my home, and then one in the West Village in New York City. And we invited people to join the practice. So we wanted to make it really beautiful and lovely and something that people wanted to visit. Because, we just wanted to have a different conversation, a different promise to our patients. So then we had to announce that we exist. We did that in the subway. We put up this ad, and I thought we did a pretty good job engaging the community, which is sort of exactly what we were looking for. But then, we got a call. We got a call from the MTA, the subway system in New York City, and they said, you guys, you got to take this down. It's encouraging graffiti. And we're like, well, yeah, exactly. That's exactly what we're trying to do. So then we called up the local news and said we're being censored, which got a nice news story about it and drove another 500,000 people to the site. So the media is pretty easy to hack. But in exchange, I think we put up something a little more sort of appropriate. And this is exactly what my life has been for the last 10 years. It's about taking something very complex and very complicated from the patient's perspective and making it dead stupid simple for people. And really, everything I've done is just a response to what I call primary care 1.0. And that's what we do today. That's what most doctors do today. Primary care is the front line. This is a definition taken from the Australian Department of Health. And it basically says it can be provided in the home or in the community. And it's talking about general practices. It's basically talking about a brick and mortar space. But that's framing it as the tool, not really the problem. And to me, the problem is, how do we maximize health in a population? And is the tool that we use the best tool we can imagine? So what does this look like every day for us, practicing doctors? Well, it's like, how can we see more patients, right? And then how can we chase these quality metrics so that we know we're doing a good job? But Goodhart's law, which is one of my favorite laws, it says that when a measure becomes a target, it ceases to be a good measure. Makes sense. But the primary care tool that we use every single day is an appointment. It's a physical exam room. It's an unstructured conversation that you're having with someone. And it's payment for time. And if the patient needs to see you again, they start that entire process all over again. So how is this tool used to solve a patient's problems? Well, it's 2.7 times a year a patient uses this on average for folks 18 to 65. And there's typically about 10 to 12 minutes per episode. So it's an interesting tool. I don't know how effective it is. Patients forget about 85% of an oral conversation, right? Does that mean we're 15% effective? I don't know, maybe so. But there's 27 minutes per year. That's what you get with people if you have 10 minutes a visit. At 15% retention rate, that's about 4 minutes of really good, memorable conversation. So then what's our productivity per visit? Well, you take a history, catch up, ask them some questions about their kids, that kind of thing. You do an exam, it takes about 20% of the time. You communicate a treatment strategy, that creates about 20%, that's about 20% of the time as well. There's some busy work in there, 20% of the time, and then documenting the interaction. There's a study that recently came out in America that said 40% of a doctor's day is fiddling with the EMR and documenting. So the next question is, well, this is our tool. Do the patients want this tool? I was meeting with one of the execs at a Florida hospital, this is about 9 months ago, and he said something really interesting. He said 50% of people in our catchment area do not have a primary care doctor. And he said something interesting. He said, well, and 25% of people say they don't even want one, So that's interesting to me. If a quarter of people in America don't want a primary care doctor, what are they doing? Where are they getting their care, right? Well, those are people that just want their problem solved. They don't want a relationship. They don't really care about a relationship. They might even think that, if I go see a doctor once or twice a year, it doesn't constitute a relationship. So the tool that we're using is a process, and I want to stress this to you all. It's an unstructured process, and that's because it's haphazard. It's an oral conversation. Sometimes you're listening to a patient, sometimes you're directing a patient, sometimes, she wants to tell you about her birthday party 6 months ago. But you have to be compassionate, you have to listen. And when you think about it, if it's an unstructured oral conversation, it's pretty difficult. It's pretty difficult to make sure that you're covering all the bases and not going down the wrong rabbit holes. This is in contrast to a structured process. And a structured process is what got me here today. It's the fact that that lovely Qantas took off very easily, landed very easily, everything's safe. And that happens 45,000 times a day in America, right? So that's a structured process. It's the checklist-driven things that guide complicated scenarios. I want to explain that it's impossible to scale unstructured processes, right? So what can you do? You can try to see more patients in the same amount of time, but there's only so many hours in the day. We can't do much more. Maybe we see 23 patients a day. Maybe we can get up to 25. I don't know. But you might be able to increase output maximally 10%. But patients hate that, and that makes sense. It's not thinking about how I can go from 23 patients a day to solving 50 people's problems a day. And it's an important distinction. So where does this tool excel, the tool that we have? Well, the complex issues that regular people have whenever you need regular in-person physical exams. But most people just don't need this. Most people just need their problem solved. And then you have to look at how people use it. So if 50% of people in a population spend 3% of costs, they really aren't looking at a relationship. They're looking at the occasional, hey, I just got sick or hurt. I need some help here. And then there's these 45% of people that spend about 47% of the costs. And then there's 5% that spend 50% of the costs. That's a different problem. The folks that are super intensive need a very different solution than the folks, which is the vast majority of the population, that have relatively minor occasional needs. So how did healthcare respond? Well, the first thing we did was say, there's technology. We can build something new. It doesn't cost us that much anymore. So we created something called telehealth, which is interesting, It's typically a phone or a video visit for 10, 12 minutes with a doctor. But you see what it's doing? It's sort of layering this unstructured conversation that we all know and love and adding phone or video. It's the same conversation. It's the same unstructured issue. The only benefit is that patients don't have to travel. and which is great, especially in rural areas. But what are the limitations of these things? Well, a 10-minute unstructured conversation, it's got the same time sucks that consume our time as physicians. It's a random doctor, typically. You can't follow up. You can't order tests. You can't do a physical exam. So what does that mean? Any new innovation that you see out there, you need to say, how effective is this? How capable is this at solving everyday problems? So you look at the sort of bottom of the capability, spectrum, and there's Google, right? Everybody has access to it. It's 24/7. It's great. We're all sort of first-year medical students now. Every patient, we all have access to the information. But it really can't solve your problem. It can just help you sort of know and learn about things. And then there's a nurse triage line. It's great. It's a nurse that you can call that normally ends with, you should go see your doctor. And then there's this doctor via phone or video. So they're diagnosing roughly 20 to 30 problems. That's about how many things you can do safely. It's pink eye, it's rashes, a little cold, that kind of thing. This is a nurse practitioner health clinic. That's somebody that can actually see you in person. They can do exams, they can do tests, that sort of thing. But they can handle roughly 75 diagnoses. Most of those are protocol driven. There's a house call doctor, there's a primary care doctor, there's this thing called Sherpa. Talk to you in a sec about that. Specialist visit, you get the deal. It gets all the way up to university hospitals that are solving as many problems as we can think of. So today, do patients want this? How do people communicate with their phones? There's about 80 billion messages sent per day. It's via Facebook, WhatsApp, iMessages on your iPhone, emails, that kind of thing. There's only about 5 million Skype or FaceTime calls. That's 0.006% of all communications. It's for family, loved ones, people you know, coworkers, that sort of thing. Not really for strangers. People don't use it that way. They don't use it for customer service either. And this isn't a new thing. Skype's been around since 2003, FaceTime 2010, Facebook Messenger launched video chat in 2015. It's just not taken off. People don't like it. It kind of makes sense. I don't know if people want these things. For example, Teladoc is the market leader in America. It's a 13-year-old company. It's public now. It went public about 2 years ago. When it goes public, we have access to all their internal operations. So now I know the data around how people are using this. What we found is about 70% of their revenue comes from selling into insurers or employers for $1 a member per month. But that means 30% of the revenue comes from actual use. It's not that much. So when people are given access to Teladoc via their employer or their insurance company, about 1% to 3% of people use it. Last year, they did 0.08% of all doctor visits in America. This is a service that scales across America. It's existed for 13 years. And that's, after working with every major insurer. So I don't know if that's the right solution. So what I did, I said, I think something better, something different needs to happen. So I created something called virtual primary care. 6 years ago, started this company called Sherpa. I think we're the pioneers of this, of virtual primary care, and I'll explain to you how we operate. But first, virtual primary care is a pretty simple premise. You just go online first, you get care. See if you can get diagnosed and treated before you go see anybody. And if you can't get diagnosed and treated virtually, you just get connected to the person who can, who's in real life, in your local neighborhood. So it's sort of like a filter for, do you need to be seen in person? The important thing here is always remain as a consistent doctor throughout the experience. Patients can work with us anywhere from 10 minutes to 10 months. It's important to make continuity into virtual medicine. Here's what it looks like. I think. Uh-oh. Healthcare is broken, expensive, and confusing. And typically you only get about 7 minutes with your doctor. Wouldn't it be nice if you didn't have to go through this every single time you have a health issue? Welcome to Sherpa, a new kind of healthcare. We're medical professionals and insurance experts here to take care of your health, online and offline and around the clock. Our doctors and guides know they can communicate faster and easier than ever. Reach them via web, phone, or app. You get better access to health wherever you are, day or night. Our doctors aren't just board certified, skilled, and intensively trained. They're highly trusted and handpicked by Sherpa to work full-time for us because they know how to communicate the way you do. Here's how it works. You ask a question about your health. Our doctors respond with the help you need in minutes. 70% of the time, the problem is resolved right there on the spot. No wasted appointments or copays. If needed, one of our doctors will write a prescription over the web and send it to your local pharmacy, ready for you to pick it up in just a few minutes.
Do you have your insurance card?
Well, I sure do. With Sherpa on your phone, it's really easy to access all of your health insurance information.
Perfect, great.
Thank you. Or perhaps there's something more dire happening with your health. There's a sharp pain in your belly, and you're unsure how serious it is. So you fire off a message to Dr. Santana, and she thinks you might have appendicitis, and you need to see a surgeon ASAP before your appendix bursts. We'll schedule an appointment with one of our favorite specialists who can see you that day and perform the surgery if needed. Bypassing unnecessary ER visits, hospital care, saving you time, money, and Sherpa looks after your mental health too. We have plenty of specialists in our group to help you through the rough times and worries bigger than yourself. So I think I'm addicted to all things Bill Murray. You ever heard of him? With any health-related concern, contact Sherpa first. Just send us a message or give us a call about a pain or a bill or a worry, and we're going to do everything we can to help you. It's healthcare for the 21st century. Simple, accessible, and friendly. So, it's a different conversation we're having with people, right? It's a different way of talking to people. And we're just saying we're different, you know? But most importantly, we're saying come to us first before you do anything else. And I'll give you another example of what this looks like. So I'm going to talk a little through this, so if you could turn it down just a tad bit. So patients launch the app. They create a concern. It's a case. They choose, I'm sick, I'm hurt, something like that. And then they tell us what's going on. They write a paragraph or two, typically. Then they said, 25% of the time, they submit a photo. And then our doctors get that. We read it, and we say, you know what? We have a lot of questions. So we fire back about 25 questions on average. People answer them on their own time and terms. We get them back. Occasionally, we order tests. So, for example, this person needed a chest x-ray. They see the results in their app. The doctor says, you know, here's a diagnosis. We write a prescription through the app. You as a patient choose your pharmacy. And then a few days later, or maybe 24 hours later, we follow up. We say, how are you doing? What's going on? It's pretty simple for people. What's interesting about this, we found over the last 6.5 years that 70% of all issues that come at us, and we say to, you know, come at us for anything, 70% of primary urgent care issues, about 1,500 conditions, can be diagnosed and treated without the time and money spent on visits to doctors, urgent care centers, or ERs. That's a pretty staggering number. But when you think about it, whenever you're in the office with the patient, and you say, does this person really need to be here? It kind of makes sense. We really invented this concept of virtual primary care to fix some deficiencies in the other solutions. Telehealth is basically a little bit better than nurse triage. Traditional office-based primary care doesn't scale, but when you marry telehealth with primary care, you get virtual primary care. And instead of days or weeks that patients are waiting to see us, we respond within, on an average, about 12 minutes. This isn't real time. So what that means is 50%, virtual primary care is 50 times more effective than Teladoc, and 95% as effective as a PCP, at less than half the cost. So this is a little bit heresy, but basically adding an office to a PCP only makes them marginally more effective. So I think this is an entirely new category of healthcare delivery. So why? Well, it's based on continuity. It's accessible 24/7, 365. Most communications are conveniently not real time, and this benefits both. It benefits me, the doctor, because I can basically triage my own patients coming in, and I can concentrate on the things that are most urgent. But it also benefits the patient, because the patient's busy. They're just leading their life. They might be at work, but they might need to talk to a doctor. So we might, fire off a few questions to the patient, but they can get those questions after they're done with their work meeting and then answer them. They get back to us when it's convenient for them. So we use chat, we use photos, we use phone, we use video, but very rarely. We've jumped on video about 4 times in the last 6 years total. We use a lot of data. We share data. Patients share data with us. We prescribe. We order tests. Patients can see their specialist consults that we refer them to, all within the app. And only when it's necessary do we jump on the phone. And that happens about 5% of the time because, as we all know, sometimes it's just easier to talk in real time. So we can order tests, we can prescribe, and most importantly, we own the progress and the outcome over time. So we treat simple things like UTIs, all the way to really complex things like pneumonia, diagnose cancer on the regular. We have 2 roles, basically. We diagnose and treat, or we just coordinate care for your next steps. And whenever you go in person, you're always going to see the most appropriate person. So it's very appropriate, effective, and cost-effective, I think. We pay our doctors differently, and our patients and our clients pay our doctors differently. It's not fee-for-service, for the most part. So it frees our doctors up to not focus on volume, focuses on communication and problem solving. So it's hyper-efficient. Because it's asynchronous, every single moment of the doctor's time is devoted to problem solving and communicating. And I'll show you how we do that. But for every doctor, we take care of about 3,500 patients, which is pretty game-changing if you think about what that is. Sherpa's all our doctors do. They work full-time for us. We don't hire anyone with less than about 7 years experience. We found that we don't want the doctors fresh out of residency. We've never had that, actually. Every doctor that has ever worked for Sherpa continues to work for Sherpa. So it's something they enjoy. They work out of our office in New York City together as a team. They're not, at home. It's not random doctors. They don't know each other. It's a very tight-knit team, and that's important. We built our own tech from the ground up. We have 2 sort of interfaces, one for the patients, one for the doctors. So for the patients, they're going to use this 2.7 times a year, right? They're going to create 2.7 cases a year. Those cases might last anywhere from 10 minutes to a couple months, though. So we want to make it dead stupid simple for them. But the first thing they do is go in and they create cases. Once they create a case, our doctors then have their interface, and they see that a new case is in, or they see that new activity has happened on a current case. So you can think of this as like when your computer breaks and you start a sort of customer support ticket tool kind of concept. That's what this is. And then it's sort of like an EMR as well, right? But it's an EMR that's not focused on sort of billing and communicating with insurers or the government. It's actually just a communication and problem-solving engine. So within cases, doctors can send messages. We can ask questions of the patient, structured questions. We can prescribe, we can order tests, we can make referrals, and we can, just follow up with people, and that's very important. E-prescribing is baked in. We worked with SureScripts, so that's very easy to do. We also order tests, so we can order lab tests, we can order imaging, and we get those results back into the case. That's a pretty seamless process for us. And then it's also like a contact relationship management software, a CRM. What does that mean? Well, in order for us to deliver care appropriately, we have to coordinate next steps when necessary. So we keep track of all our specialists that we refer to across America, all the urgent care centers and the ERs, dentists and things like that. So we have about 5,000 professionals in our network. These are people that we've sort of vetted. We've said these people are on brand for Sherpa. They, they've been trained well, they're out in the communities in which we're operating, and they would just know who we are, and we refer to them. So we're referral based for people like that. But to me, Sherpa is about scaling a doctor's time, right? We've automated much of the history taking for the most common 250 chief complaints. We've automated most of the treatment protocols for the most common 250 diagnoses. And because this 95% of what we do is just messaging back and forth, that is the documentation. Our doctors literally cannot document anything that the patient can't see, right? So they don't have to spend 40% of their day documenting. That in and of itself makes them hyper efficient. So what does that look like? When a patient comes to us with abdominal pain, for example, we built a question set around abdominal pain. This question set has 28 questions. They're designed to rule out anything terrible, but also designed to give us the right rabbit hole we need to go down. So we fire off all those questions at once. The patients then get them, and they answer them. And that's what this looks like. You know, it's just, it's unstructured, so it's in the patient's own words. When you think about an exam room, a patient is sort of, it's time sensitive, you're intimidating maybe. They really have to think on their feet. They don't get a chance to say, you know, I've been thinking about these all weekend. And that's what happened just, you know, a couple months ago. We fired off a question set on a Friday, and on Monday morning, you know, we got these answers back. Our system is designed to say, where's the next step stalled? So for 2 days, our system was like, there's a question set out, it's not being answered. But then on Monday, she got back to us, and she said, I've been thinking about these all weekend. And that, to me, just kind of blew my mind, because that's really the type of communication we need to be having with our patients. And so then whenever we make diagnoses, whenever we have a treatment plan, it's all right there. They can log in from any device, iPhone, iPad, Android, web, whatever they need, and they can see the entire automated plan, right? Now, it's automated probably 90% of the time. Obviously, we go in and tweak the information to make it, you know, specific to the patient. But when you think about what we do as doctors, it's a lot of the same stuff over and over. So we just automate that. So what's really unique about this from a doctor's perspective? It's team-based, right? Our doctors collaborate. When a weird case comes in, remember, they're all in the same room, in the same office. One of them looks at it and says, hey, can you guys jump into this case and let's talk about it? They talk about it, and then the patients get back, and then they get back to the patient as a singular voice, one doctor, after the group discussed it. Because, you know, it's better to have 2 brains or 3 brains than just one. The other thing that we can do is use time as a diagnostic factor. We can say to people, because we're not exam room driven, we can say to people, I actually don't know what's going on right now, but let's just reconnect in 4 hours and see how you're doing, right? That's super easy for us to do because we just fire off a message. Most of that's automated, just to check in. And the other thing is, every doctor can view a case and read the entire conversation. So no doctor has privileged information. And then 95% of what we do is asynchronous. It's not real time. And I think this is the only place in healthcare where the vast majority of the conversation is analyzable data points. So our doctors just get to show up, deliver care. They don't have to document. They don't have to deal with insurance companies. All they do is communicate and solve problems with patients. That's it. So that's why they love it, you know? What's interesting about this, one of our doctors is married to a gentleman who lives in Vienna, right? Now, she's an internist and an allergist. And so for about 4 months out of the year, she's visiting her husband. And she's treating patients in America via Vienna, right? It's very difficult for her to have a real job, right? Whenever you're gone for 6 months out of the year. So she gets to practice medicine essentially 12 months out of the year. And I think she's grateful for that. So bring this to life a little bit. Let's talk about a little UTI. So you create a case as a patient. You tell us what's going on. You might have said, hey, you know, I get this once a year. I know what it feels like. Never had any complications. We ask a couple questions. If necessary, we might send you to the local drugstore to get just a, you know, do a UTI test. But then we, you know, prescribe within the app. You as a patient get notification that there's a prescription waiting for you. You confirm your pharmacy within the app. You choose your pharmacy. And then you pick up the medication, you know, an hour later, take it, we check in 24 hours, we check in 3 days. Done. No visits, no nothing. We do moderate things like pneumonia, like I said, and you saw in the video. We'll send you to get a chest x-ray. But this isn't 2 visits. It's not an initial diagnostic visit. And it's not a visit to follow up, right? It's just, let's check in on you. Let's see how you're doing. Let's ask you the right questions. So we take, something that would typically take 2 visits and turn it into 0, and much less expensive. So, give you another example, testicular cancer. Someone reached out to us as an individual who joined Sherpa, and he'd been, having some weirdness. So every question we asked him suggested testicular cancer. So we sent him to get an ultrasound, confirmed the mass, and then got on the phone and called up immediately our urologist that we refer to on a regular basis in New York City, said, hey, Bob, we need you to see somebody today. And got him in that day. And within 72 hours of joining Sherpa, he was back home after a diagnosis and after surgery. So when you blow up the entire concept of the exam room being the exclusive domain of communicating and problem solving, things get done very quickly. So think of us as like a neighborhood, it's not a neighborhood doctor practice, it's a nationwide doctor practice. We're available to anywhere, to everybody, pretty much everywhere, 24/7, 365. You can see Arkansas is not one of them, unfortunately. They hate telemedicine. So we're not there. We're paid mostly by employers. So we have about 150 clients, Tumblr, Foursquare, Casper, pretty forward-thinking clients. And then when people have access to us, it's free for them. So 50 to 70% of employees by the end of the year use Sherpa first. And that's what we ask of them. So it's really just simple, transparent pricing for groups, and this is part of our deal. Now, I understand that pricing is different in every country, but I'm just presenting this to you to show you how much it costs in America to do what we do, and be an independent, profitable company. And I think this is important. We're a sustainable, profitable company. We're not VC funded. We are just an independent, profitable company that we depend on our revenue to operate, pay our doctors, pay our operating costs, that's it. So we figured that out. The employee in the first year typically pays $100 per episode of care, and then that is used to establish a baseline to de-risk the company. And in the second year, we basically lock in the rate and say this is how much you pay per year per employee. So pricing for individuals. Individuals can join as well. It's $99 for 30 days of care. We chose 30 days because the vast majority of things will be resolved in 30 days. And then, or you can, if you have some chronic issues and that kind of thing, you can get unlimited care. It's about $270 per year. As many times as you need it, you can communicate with us every day if you need. People don't do that, but you can. So how does Sherpa save money? And I think this is the real kicker here. Because it's not just about the experience for doctors and patients, it's about, how do we drive down costs so that healthcare is more affordable? So right now, most insurance plans and self-insured employers spend about $40 per member per month on primary care costs. Sherpa costs about $20. Our overhead is just extremely low. And remember, it's hyper efficient. It's about 1 doctor per 3,500 patients. And then the next thing that we do is we direct these expensive downstream costs to preferred specialists and facilities, places that aren't going to price gouge you. They're on our team. So that's what we do. So as you can see, it's all about how doctors and patients can communicate and solve problems better. And the other thing is how healthcare is paid for. And you have to change both of those at the same time because they go hand in hand. So I'm going to talk to you a little about video visits and sort of implementation. So, this is what I showed you was sort of the ideal. And I'm a bit of an idealist. I understand that. But how can we be practical about this? How can this be implemented? And many countries across the world are thinking that telehealth is the only way to go. Well, in America, I think that we pioneered it, but hospital networks have really tried to roll this thing out significantly. They typically spend about, anywhere from $5 to $10 million on the technology. And then they see about 50 to 100 visits per month. So that doesn't sound like a success story to me, right? And I think it's important. It's important to realize that, there's a lot of hierarchy. There's a lot of politics involved. Change is pretty hard. An example of this is the introduction of anesthesia in the profession. In the 1840s, anesthesia was new. And there was a guy named Dr. Mutter who went around, traveled the east coast of America saying, well, look at what I'm doing. Look at the surgeries I'm doing. These patients are out, you know, and I can do surgery better. And the surgeons were like, you know what, but we listen to the screams of our patients to guide our surgery. Change is pretty hard. You're always going to get pushback, and I understand that. But when great changes occur in history, when great principles are involved, as a rule, the majority are wrong. This is a guy named Eugene Debs. He ran for president of America from a jail cell. He got 5% of the vote, which is 14% less than Donald Trump. But take that with a grain of salt. So it's considered tech, not a service. Sorry. That's how hospital and sort of delivery networks are looking at video telehealth or any sort of telehealth. You know, but the issue is an espresso machine doesn't really make a Starbucks, right? It's also not a carefully designed consumer-obsessed service. It's mostly purchased by the IT department, and vendors sell this as technology. And then it's up to the doctors and the hospital networks to sort of implement this. But a carefully designed consumer service looks more like this. It's a Starbucks experience map. Every single touch point in Starbucks has been designed. And every single restaurant that you go to that is just lovely has been designed, and every single process has been thought out. So we did the same thing for Sherpa. That's all we did, was just design the process. And then we put it up on a wall so that everybody can see it in the company and see what we do. So patients really aren't that interested, you know. Like I said, if people wanted this, Apple would have been, you know, delivering customer service via video years ago. They actually did do that, but they pulled it. It didn't work. And then, you know, Teledoc's not really working. It's only for pink eye and rashes. People get frustrated when something isn't useful. If it's only useful for 20 or 30 things, they're just going to abandon it. That can be very detrimental to the entire concept of digital health. And then, you know, for a hospital system, essentially 1% engagement, which is what you see in Teladoc, means literally 100 visits a month. And then doctors aren't that interested. You know, they don't want to treat pink eye and rashes all day. They want to actually communicate and solve problems that are real. They don't want their day interrupted by the occasional video appointment. It's more intrusive than sort of patients emailing them because it's expected to be delivered in real time. And then coordinating doctors' and patients' schedules via video is a nightmare. And they also just don't want to get paid less doing video. So there's chicken and egg staffing issues as well. If you'd roll out a service like this, it's pretty low usage for a while, but you still have to staff it. So that gets expensive. And it's just, you know, mostly annoying to most health professionals to be able to staff these. So there's pretty huge ROI issues. You know, if a hospital system pays, you know, $10 million and gets, you know, 100 visits a month, that's about $49,000 in revenue if it's $49 a visit. So video visits, I think, only appeal to about 1% of people and represent only about 0.07% of all doctor visits. They're great for rural areas, for places that are difficult for people to get to doctors, but that's only if those rural areas have decent internet connections. Those rural areas most always have internet connections enough to message with the doctors. And then if a doctor is ready to deal with the logistical issues. So the other thing is doctors need to be either virtualists or in-person doctors. That's it. If you mix the two, it doesn't work. And I'm very, very convinced of that. Our doctors practice exclusive virtual medicine. So how can we think about implementing this? Well, acknowledge this is a political, cultural problem, as we know. But change involves leadership with a vision. It inspires those most disrupted to see a bright future, though. And GPs must challenge themselves. If not, I think they risk losing public trust. You got to deliver a service that resonates with people. People overwhelmingly message asynchronously. They want the equivalent of an Uber showing up every 3 minutes, or in 3 minutes, and they'd rather work with somebody that they know rather than a stranger. And people have spoken, I think. It's got to be treated as a consumer experience, not technology. Instead of spending $10 million on technology, spend that money on marketing that changes behavior. And the behavior you want is get care online before you get care in person. It's not difficult. Instead of calling up a taxi cab, fire up Uber. We get to follow other industries' leadership here. And it's a new promise and a brand. You know, most people don't sort of have a great feeling toward the consumer experience in healthcare. It's sort of like Microsoft. But then Microsoft also owns Xbox, which is a cool brand. You know, you can actually target people, get new types of customers, early adopters, and move forward with folks. And the other thing is to outsource it. You know, whenever you're staffing a service like this, if you're not pooling resources so that you're getting a huge catchment area, so maybe 50,000 people have access to this, the first day, hardly anybody uses it, but the first month, you get 50. Second month, you get 100. Third month, you get 300, that sort of thing. So it grows slowly. Pool resources. And when you treat this as a service, not a technology, everybody wins. So hospital networks save money. There's no staffing, no training local reluctant doctors. You get to have a new brand, connect with new patients. You get referrals for in-person care, and patients get a service that resonates with them. So virtual primary care enables primary care 3.0, right? And I'm not saying what we do right now is primary care 1.0. I don't know what happened to primary care 2.0, but primary 3.0 is just something totally different. It's about problem solving over in-person relationships, and I realize this is heresy, right? But for most people, they're just living their life. They just want their problems solved quickly and effectively. But some people value and need in close personal relationships. But we assume today that everybody wants the latter. Primary care 3.0 is a process. It's a carefully designed process. It's a structured process. It mixes online and real-time conversation to solve the most problems with the fewest error-proof steps as possible. It's a human-powered service. This isn't technology. It is literally humans augmented by technology. It's always on. It's always available. It's a virtual service that lives anywhere in the cloud. It's quickly, accurately, and cost-effectively diagnosing, treating, and/or connecting people with the right care at the right time, every single time. It's a tech platform. It focuses on health professional-patient communication and problem solving in the forms that people regularly use and are comfortable with. It's intelligent. While human-powered, the data within the platform enables machine learning to augment the most appropriate care. It's constantly learning. If a person answered a series of 25 questions in the following way, there's a 98% chance they have this diagnosis. That's real. You can do that with data. In order to cost-effectively diagnose your suspicions based on those questions, you should order exclusively these tests. That's data. That's something you can do. And if a patient has this diagnosis, there's a 99% chance they'll respond to the following treatment strategy. That, again, is data. And it needs to be structured. It manages simple and complex issues, anywhere from acute and quickly resolving to chronic, daily, almost all physical care. Almost all physical care can still be augmented via online communication. Sometimes this is an old person. Sometimes this is their grandson or granddaughter communicating with their doctors on their behalf. It really does solve the mobility problem. Most primary care was sort of created in the time where nobody really traveled away from their neighborhood. So neighborhood-based clinics made sense a while ago. It solves these on-demand consumer expectations. People want an Uber in 3 minutes. Apps can do that. Care needs to be available in minutes, not days or weeks. And it's enabled by virtualists. Primary Care Needs 3.0 knows what you need before you spend time and money on in-person care. An in-person visit to a GP, sorry guys, is very, very rarely the most appropriate first step. Sorry. Whenever we do refer, 55% of the time goes to specialists. We are GPs. We're managing this. We know what the person needs. 55% go to specialists, 30% go to urgent care centers, 5% go to GPs. And these are the folks that are like, you know what, we've identified you as somebody who would value and need in-person relationships. That's also a symptom of the fact that it's very difficult to get into GPs in the major metropolitan areas in America. It's a 22-day wait in New York, 44-day wait in Boston. So it's difficult to refer into GPs. 5% of the time we send you to the pharmacy, nurse practitioner clinic, 5% of the time you're going to the ER. But primary care is not just diagnosing and treating. It's a super connector. We all know these people, the people that knows everybody, the person that knows everybody. I can't help you, but here's who can, I'm not the right person for you at this point, but I know exactly who you need to see. We're super connectors. Primary Care 3.0 is obsessed with remote objective analysis as well. So if we can't do physical exams, what are the proxies for them? Well, if you ask an ER doc if they're suspecting a broken leg, can you jump up and down? Well, if you can, probably not a broken leg. Apple Watches, it's just getting started. I don't know what this means yet, but it can detect heart irregularity with 97%. Again, might be nonsense. But these are the kind of things that we have to be paying attention to. A lovely Australian company called ResApp listens to the sound of your cough, and using the characteristic sound of your cough is associating whether or not you have asthma, COPD, pneumonia, that sort of thing. So it uses the iPhone app, the iPhone's speaker to listen to the sound of your cough. Oops. There is also CellScope, which is an iPhone attachment that allows you to look into your ear. And then there's just the old-fashioned, UTI strips at Walgreens or any clinic, any pharmacy in the local area. So those are the things that we need to be paying attention to. How can we sort of augment and do physical exams without actually doing physical exams? So Primary Care 3.0 is also cost-conscious. The most expensive thing in healthcare is the doctor's pen, right? It's our orders. Most of the time, we don't know how much our orders cost. So it's important that the doctor knows at every stage how much something costs. And every patient should know where to get the service for the lowest cost. For example, when they're choosing their pharmacy in Sherpa, in America, there's a price tag next to each drug at each pharmacy, so you know where to get the cheapest medication. It's outcome-driven. It's not easily gamed, right? There's no reason every patient can't have outcome data attached. The only reason it doesn't exist today is because it's very difficult to communicate with patients once they're outside the exam room in a structured way. If we have a direct communication link to them at all times, we can ping the patient at an appropriate time and say, hey, just checking in, how are you doing? That's something I think it's our #1 thing that patients love about Sherpa. So each chronic case should also have a plan with a buy-in on a daily, and have goals for daily, weekly, monthly goals. It tracks expectations, right? Virtual primary care works for, I'd say, 80 to 90% of the needs of 80 to 90% of the population. We really need to wow our patients with innovations, and we need to track patient satisfaction. For example, 3 days after our doctors archive a case in Sherpa, you get pinged as a patient to say, how did we do, right? How are you doing? How did we do? And that allows us to understand outcomes in a very detailed way. It's aware of its limitations. This isn't perfect. This isn't for everybody, but it's for a lot of people. Some patients just need comprehensive in-person physical exams and in-person relationships, and that's good. We need to identify who those folks are and get them really sort of the right services and really wrap their arms around them and get them the most comprehensive care that they need. And importantly, I think this is an open source platform. I don't think this is a private company doing this. I don't think it should be. This is a public utility. This is a public good. This is a process that should be designed through experience and through consensus. And it's really a common benefit, a common good to benefit us all. So, guys, I gave you a picture of the future, right? But I think we're at a critical moment here. As GPs, I think we can define the future we want for ourselves and for our patients. If we don't, someone else is going to design it for us and probably slowly carve us out. It's not going to be the future we'd like to see. I presented a vision today. It's something we've been doing for the last 6 years in America. Hopefully this excited you, but hopefully it also made you a little uncomfortable, maybe scared you a bit. But I think it's a magical combination that often leads to positive change. So I wish you the best. Thank you very much for this opportunity, and good luck.
Thank you, Jay. That was a thought-provoking presentation. I will allow time for 3 questions, but I do a snap poll. How many in the audience would use Sherpa if they had access to it? Just a show of hands. All right, are you okay for a couple of questions? Come back, Jay. Yes. John.
Jay, I'm John. How you doing? 2 really quick things, mate. One, just to increase the heresy, how many of those consults could have been done without a doctor at all, given your systems? Which is maybe, and to go in reverse, where do Sherpa patients get health promotion, prevention, and screening? Thank you.
Yeah, good question. Our brand from the get-go has always been you're talking to a doctor. I think in the future we can sort of evolve into a more front lines approach, you know, a nurse practitioner, a medical assistant. For every 4 doctors, we hire a medical assistant. They're working with the patient, actually in the case, communicating with them, saying, like, what's your insurance, and really sort of asking their preferences and that sort of thing. So we do use other people than doctors right now. They're not health professionals, though. But percent-wise, yeah, I'd say 40% of things could be handled by a non-doctor. And I think the future of this is definitely the doctor being the strategic decision maker, because I think that's what we're good at. I don't think we're good at day-to-day details and execution, right? I think there's a new profession that should come online to support that. Sorry, what was the second question? Okay, sorry. Sure. So I'm trained in preventive medicine. I'm a master's in public health, that sort of thing. I'm a big believer in the US Preventive Services Task Force. They publish guidelines on a regular basis saying, does something have, you know, evidence behind it? So you plug in 4 data points per person, and this is very automated. And given the results of that query, you can say you need your cholesterol checked, you need your blood pressure checked, that sort of thing. So we just basically, when somebody hasn't had their cholesterol checked and they're 35 or something like that, we just order the test. We get it, right? So, but there are things we can't do. We can't do a blood pressure, right? But we can say next time you're in somewhere, or here, spend $99 and get one of those iPhone versions. We can do that in companies too. Have sort of health fairs in companies. So that's what we do right now. But I think there's a lot of room for improvement there, for sure.
I have a question.
Hi, Jay. My name's Marisa. Thanks. That was really inspiring. I had the preventative questions, so that's been answered. But I also wondered about the 24/7. And do you have a roster for I'm on the 6 a.m. shift or the midnight or whatever? And as part of that, what's your agreement that you'll be responded to within 3 minutes like Uber?
Yeah. So we have shifts, right? The app is live 8 a.m. to 8 p.m. Eastern time. After that, within the app, it says that the doctors aren't online right now, but if you need us urgently, call us. And there's just a button that you press in the app, and it calls the doctors directly. So they all take turns covering night shifts. We get 2-3 calls a week per 10,000 people. So it's not bad. I think just giving people access, to me, like accessibility is the best prevention. And sort of giving people the feeling that a doctor's available within minutes. They can also do that during the day. They can talk to us immediately if it's an urgent issue. So that's how we communicate it. Use the app, use messaging for non-urgent issues, but call us if it's an urgent issue. So it's very shift-based. It works very well for the doctors. It's 8 hours. 95% of our doctors are women. Most of them have kids. It just really plugs in nicely to their lifestyle.
We only have time for one more short question, if that's okay, but I'm sure you're available on Twitter as well to respond as well. So one more question.
Hi, my name's Susan Clark. I just have a question about your demographics. So when you were saying that testicular cancer is your complex case, for me that would be the simple case. Most of my patients, I work remote, and most of my patients have at least 3 very, very complicated issues. How does your system deal with these patients? And I'm suspecting that your demographic is young and they only have one thing at a time, but how do you deal with the complex patients?
Yeah, so those are the folks that we identify with, like, you know what, it'd be great for you to have an in-person relationship with the GP, right? So then that's what we do. You know, our goal is not to, our goal is just to get people the best care they can get, right, from the most appropriate place. 30% of the time, we're not the most appropriate place, right? But we're gonna help you, sort of guide you through that process and build a care team for you. Our demographics, it's upper 30s is the average age. And I think that's important, right? It's very difficult in any industry to create a service that works for absolutely everybody. You can't do that, it's impossible. So what we try to do is say, let's start with the folks that get it, like Facebook did, like the iPhone did, and then gradually sort of build out the processes and the structures there, and sort of gradually scale to people with more complicated issues. So you can't, it's very difficult to start with them, and that's why we chose to sort of solve the low-hanging fruit first.
That's great, thank you very much.